My name is Stephen Schwartz. I'm the Amundsen Professor of Ophthalmology at UCLA's Jules Stein Eye Institute and the Director of the Diabetic Eye Disease Center at the Jules Stein Eye Institute. As all of you know, diabetes is an exploding epidemic worldwide, both here in the United States and in developing countries, and now even in undeveloped countries all around the world. A high percentage of patients with diabetes end up with diabetic retinopathy, whether it's diabetic macular edema or proliferative diabetic retinopathy. These can be devastating to vision, and we're thrilled to be able to review with you today some of the newer diagnostic and interventional techniques available to the treating retinologist to help your patient not only stabilize vision, but actually improve vision. So how can we help? Well, let's start with the diagnosis. Diagnosis has become much more efficient, precise. We have OCT, we have ultra-wide field angiography, we have a variety of other imaging techniques like autofluorescence that help us diagnose, prognosticate, and make treatment decisions. And we also have the new anti-vascular endothelial growth factor or anti-VEGF drugs that allow us to stop the disease in its tracks with direct, precise protein therapeutics, specifically antibodies and similar agents to counteract the negative effects of vascular endothelial growth factor, or VEGF. As a result, we can now intervene for patients therapeutically, diagnostically, and really bring their vision back. Perhaps more importantly, we have the opportunity to now interact with endocrinologists and work together with the patient to triangulate the disease to improve glycemic control, decrease hypertension, decrease anemia, decrease renal failure, anemia, sleep apnea, other issues that really exacerbate diabetic retinopathy. Just today, a major study was published in the world literature suggesting that high fructose corn syrup may be one of the culprits in the emerging world in terms of the risk for diabetes. In fact, countries that have high fructose corn syrup in their food chain have approximately 20% higher rate of type 2 diabetes than those developing countries which do not have it in their food chain. So that's a simple step that we can take and intervene with our adult diabetic patients when we make dietary suggestions to them. Perhaps more importantly, we can just suggest to the patient, follow the targets, try and hit the targets that your endocrinologist or internist is suggesting, such as blood pressure control with a diastolic of approximately 75, cholesterol of approximately 100, and a glycemic management with a hemoglobin A1C at under 7 or under 6.5. These should be individualized for each patient. There should be discussion. And as we all know as treating retinologists, when patients begin to lose their vision or have their vision under threat, their motivation for diabetic control increases logarithmically. I hope you enjoy the program and find it beneficial.